Welcome again to our fortnightly core masterclass series with very interesting case and discussion. The topic today being AKI following diarrhea. Thank you, our conveners, Dr. Vijay Kher, the Chairman, Epitome Hospitals, Delhi, and Dr. Lieutenant General P Varma, Principal Director at Venkateshwar Hospital, Delhi, for giving us this opportunity. And with this, I hand over the session to you.
Thank you very much, Puneet. And once again, friends, we are there. This is the 8th session of masterclass, new masterclass. And today again, we have got very learned examiner and discussant. And today it is dominated by army people. So we have got Brigadier Jairam. Brigadier Jairam is a very senior nephrologist and very learned and respected nephrologist. He served in army for almost 30 years. And after that, he is presently the professor of nephrology at St. John Medical College, Bangalore. And his student, Dr. Sooraj Hegde, is the second year DM student. He will be presenting the case. The discussant for today is General Ranjith Nair, again a very senior and learned, rather he is presently the senior most nephrologist of armed forces, serving nephrologist of armed forces. He is additional DGAFMS and he has remained professor of nephrology at Army Hospital RNR Delhi. And he will be discussing the case. And today's expert is again a very senior, very learned, respected nephrologist of India. She is Professor Anuradha Raman, and she has been ex-professor and head at Osmania General Hospital, Hyderabad. And she has also been past president of Indian Society of Nephrology, a very respected nephrologist. And she presently is still working at, I think, Sunshine Hospital, ma'am. She's the senior consultant and in charge at Sunshine Hospital, Hyderabad. I request Professor Kher to introduce the topic today and proceed.
Well, I think the topic is very interesting. The acute kidney injury related to dysentery or an acute diarrhea, but many of these patients could be confused with complement-mediated acute kidney injury, thrombotic microangiopathy, which or acute hemolytic uremic syndrome-like picture, and these could be also related to a genetic or mutations in the complement system, and complement-mediated acute hemolytic uremic syndrome remains a very important differential diagnosis in these patients. And so I feel that this discussion, we've had some discussions related to transplant in people with complement-mediated hemolytic uremic syndrome, and this would be a very interesting. And I think Dr. Jairam has will be the examiner for this patient, and I think Dr. Sooraj is going to present it, and I think it will be very important discussion, and I'm sure we're going to learn from this this presentation. I will request Dr. Sooraj to go ahead and Dr. Jairam to carry the case forward. Yes.
Thank you, sir. Thank you, sir. Good evening, distinguished doctors. I am going to present a case of acute kidney injury. So coming to the case, the patient is 19-year-old lady who is a student hailing from rural Karnataka with previously no comorbidities. She presented with complaints of fever for 5 days and loose stools which lasted for 1 day. Patient was apparently normal 5 days prior to presentation when she developed high-grade fever with chills, generalized weakness and tiredness. However, there was no history of cough with expectoration, burning micturition, headache, skin rashes, joint pains, or yellowing of eyes. Fever only temporarily responded to injection paracetamol from a local practitioner. However, 2 days after onset of fever, she had two to three episodes of loose stools, which was watery, associated with crampy type of abdominal pain. There was no history of any blood in stools, and also there was no history of vomiting and no history of rice water stools. And high-grade fever with chills continued. The loose stool subsided in a day, but she continued to have fever spikes, for which she was admitted at a private hospital for 2 days. And at the hospital, she received IV fluids and injections. However, BP remained low and urine output decreased, and it became nil over 24 hours. And she also developed swelling of the legs, face, and became breathless. And she was told that her kidneys are not working, and for which she was initiated on dialysis. She underwent 2 sessions of dialysis by catheter in the right side of the neck. And after 2 days of admission, she was referred to a higher center in view of persistent fever. Past history, there was no history suggestive of any renal disease in the past. She did not have any symptoms of easy fatigability, weakness, puffiness of the face or legs, hematuria, frothy urine, nocturia, recurrent UTIs, graveluria. Treatment history, previously she was not on any medications. There is no history of any analgesic or alternative medicine intake. Family history, no history of renal disease in the family members born out of non-consanguineous marriage, and there was no history of any diarrheal outbreak in the family members or in the village. Menstrual history, her last menstrual period was 7 days. LMP was 7 days before admission. She had regular menstrual cycle, and there was no history of menorrhagia and dysmenorrhea.
Okay, Sooraj, you may stop there. Let's go back to the previous slide. Let's summarize the history, please.
This is a 19-year-old female with the history of high-grade fever with chills for 5 days, along with the history of loose stools lasting for a single day, which subsided spontaneously. But however, during the course, her urine output decreased. She became almost anuric, for which she was initiated on dialysis. For which she was initiated on dialysis, and so based.
Okay, so that is the short summary. So before we jump into the nephrology, patient had fever and diarrhea as a prime complaint. So what do you think, what type of diarrhea do you think this patient had? Because a short diarrhea, 1 day, just few stools. What do you think, what kind of diarrhea?
Based on the history, looks like infective, sir. History of fever with loose stools, and most probably small bowel diarrhea, sir. Watery, 2 to 3 episodes. No history of any passage of blood or mucus in the stools, and no history suggestive of tenesmus. So it looks like small bowel diarrhea.
Looks like a small bowel diarrhea with febrile illness in the setting of an acute febrile illness. So what do you think would be the common causes of a febrile illness presenting with some small intestinal involvement?
Usually viral or bacterial causes, sir. Viral causes like even this enterovirus, norvac virus, adenovirus, and even dengue can also sometimes present with high-grade fever with chills and diarrhea. And other bacterial causes, E. coli, Salmonella, even Shigella, Campylobacter. These are some of the causes.
Shigella would more likely to cause a dysentery. Okay.
Yeah, dysentery more causes dysentery.
Okay, so this patient after this illness became, what do you think is the nephrological syndrome this patient has presented with?
So the nephrological syndrome, this patient looks like she is having acute kidney injury, sir. As the patient progressed over a period of hours to days, within 3 to 4 days, she became anuric and dialysis dependent.
Okay, so do you think this 2 to 3 episodes of loose stools is enough to push a young lady who was in good health into oligoanuric AKI requiring dialysis? Does this happen usually?
No, sir. Usually, there will be a large number. Patient will be severely dehydrated, but the thing is, she had developed hypotension.
Yeah. So, but tell me, leave this case apart for the time being.
Yes.
Can you tell about some clinical scenarios or some profile of patients who, with just maybe 3 to 4 loose stools and couple of days of fever, will develop this kind of a acute kidney injury? What could be the risk factors for that? Leave this patient in general. If a person after few loose stools and couple of days of fever quickly develops a AKI, what could be the profile of patients who develop this kind of a renal syndrome?
Vascular, thrombotic microangiopathies.
Say, I'll give you an example. Say patient is infant or patient is very elderly or patient is immunocompromised. That kind of patients or a pre-existing CKD. These people are more likely to develop.
More likely to
Otherwise, a young adult will less likely after few
less
loose
likely
stools to develop this kind of a severe renal syndrome.
severe renal.
Any pre-existing drugs, concomitant drugs can precipitate this kind of acute kidney injury in a patient after a few episodes of diarrhea. Can you think of any medications which could?
NSAIDs.
Okay, patient has
She
received
had
NSAIDs,
history of admission at a private hospital with IV medications. So,
yeah. So, or if the patient was previously a hypertensive on ACE inhibitor
hypertensive
and then there's
patient taking ACE inhibitors, ARBs.
if it was there. So what do
Yes.
you think in this patient now? She had none of these kind of medications. She's not an elderly. She's a young lady, student doing some degree course. Why do you think now this lady developed after a few loose stools and febrile illness, such as severe AKI requiring dialysis? What do you think? Patient was severe hypotension.
Yes, sir. One of the thing is she had high grade fever with chills. So sepsis like malaria, dengue. She also developed hypertension over the course of illness. So that such patients can produce AK with severe renal failure, anuric renal failures.
Yeah, so sepsis is more of a host response to a particular
Host response to
infection, and
a
that
infection.
depends. Yeah,
Yes,
so
sir. Yes.
patient can have sepsis after a gastrointestinal. Is it possible this young lady had some rural background? You said so. Is it possible that there was an underlying CKDU kind of a thing, and
But
this thing precipitated a renal illness? Is it possible or not possible? You may
there was no
justify.
history like suggestive of any previous underlying CKDs like nocturia or easy fatigability, tiredness.
Yeah, but keep in mind that CKDU typically patients present with advanced renal failure, they may not be symptomatic till they develop pretty
Till
advanced
the,
azotemia. So many times goes undetected till they become severely advanced renal failure. You don't have other investigations, so you don't know at this stage. Without
yes,
investigations, you cannot be very sure. But it seems unlikely. Nothing in the history to suggest any such scenario.
suggestive of.
All right. You suppose you are the nephrologist at that hospital when the patient presented to with the whatever the syndrome she has presented, and you received her there. Patient has got hypertension. Patient is urine output is decreasing. How would you assess the patient as to whether you want to give IV or you want to restrict IV fluids? What will guide your IV fluid therapy there? How will you decide?
Mainly based on the volume status of the patient.
So how will you
Patient
determine
is
volume status
hypovolemic,
in
then
this patient in this
IVC.
scenario? Yeah,
You have to
go
look
on.
for the IVC diameter. If IVC is collapsible, then you can give resuscitate with IV fluids.
Either you'll do a IVC or you will not even examine clinically. When you first
No,
examine clinically,
yeah, clinically to look for signs of dehydration. Uh,
So what will you look
yes.
for?
Sunken eyeballs, dry mucosal membranes, oral cavities, loss of skin turgor. So
Mm.
mainly look for
So
signs of hypovolemia. dehydration, sir. And then,
So how good are these signs of clinical signs of hypovolemia in assessing volume status as per you? They are good, not so good, very sensitive, poorly sensitive.
not entirely reliable, sir. So
why? Tell me some few causes where the mucous membrane will be dry, but the patient is not hypovolemic. Somebody's mouth breathing, mouth will dry, but patient may not be hypovolemic.
patient,
Say skin turgor is decreased,
yes, sir.
but patient is not hypovolemic. Give some example.
Underlying,
Sorry? Very elderly patients, the resting
yes.
is tough, so the skin will tend, but they are not actually hypovolemic.
Hypovolemic.
So there are so many fallacies. So you want to look at the IVC and see collapsibility to decide. All right. How will you know that patient is being already not taken a lot of fluids and already not fluid overload? Is there any other method of knowing that? How will you assess that? Hypervolemia?
Based on examination, like any edema, if she has any edema, pedal edema or generalized edema, and on auscultation, the presence of any crackles, like suggestive of pulmonary edema, that may be suggestive of IV fluid.